Hello and welcome to this learning module. This module will discuss pre-hospital assessment and management of spinal injuries. This video is intended to supplement any readings or coursework assigned by your instructor. The objectives for this learning module are: number 1, review the anatomy, physiology, and pathophysiology pertinent to spinal injuries. Number 2, evaluate patients presenting with an injury to the spinal column or spinal cord. And number 3, provide pre-hospital care for patients with traumatic spinal injuries. In this image, we see the spinal column, which is also known as the backbone or vertebral column. It is a flexible structure that forms the central axis of the human body. It is composed of 33 vertebrae that are stacked on top of each other and are connected by ligaments, tendons, and separated by intervertebral discs. The spinal column consists of 5 divisions: 7 cervical vertebrae, 12 thoracic vertebrae, 5 lumbar vertebrae, 5 fused sacral vertebrae that form the posterior wall of the pelvis, and the 4 fused vertebrae that comprise the coccyx or tailbone. The spinal column provides structural support for the upper body, protects the spinal cord, and provides mobility. Each vertebra has a body, a vertebral arch, and various bony processes that provide attachment points for ligaments and muscles. The intervertebral discs act as cushions between the vertebrae, absorbing shock and allowing for movement. Ligaments and tendons connect the vertebrae and provide stability. This image illustrates the central and peripheral nervous system components. As we mentioned earlier, the central nervous system includes the brain and spinal cord, and the peripheral nervous system consists of 31 pairs of spinal nerves that conduct sensory information to the central nervous system and conducts motor impulses from the central nervous system to the body. The spinal cord is a long cylindrical bundle of nervous tissue that extends from the brainstem down the vertebral column. The spinal cord is responsible for relaying sensory information, transmitting motor commands, coordinating reflexes, and regulating body functions. This image illustrates a reflex arc, which is a neural pathway that controls an involuntary response to a noxious stimulus. Reflex arcs allow for faster actions by activating spinal motor neurons instead of sending signals all the way to the brain. In this image, the reflex arc detects the hot stimulus from the open flame and responds by immediately withdrawing from the hot stimulus. This is an evolutionary adaptation that helps organisms survive. Spinal column injury occurs when there is damage to the vertebrae. These can be fractures or dislocations that result in pain, tenderness, and often a palpable deformity of the spine. Vertebral dislocations and fractures can lead to damage to the spinal cord and nerves. Spinal cord injury is damage to the actual nervous tissue of the spinal cord. This can cause a disruption in movement and/or sensation. A spinal cord injury may produce pain independent of movement or palpation. Other signs and symptoms of spinal injury include an obvious deformity as you gently palpate the spine, numbness, weakness, or tingling in the extremities, and soft tissue injuries in the spinal region. Patients with severe spinal cord injury may lose sensation or experience paralysis below the suspected level of injury, or may lose control of bowel and/or bladder. A complete spinal cord injury occurs when the patient has a transection of the spinal cord, meaning the spinal cord has been completely severed. This will cause a loss of motor, sensory, and autonomic function below the site of the injury. An incomplete spinal cord injury may exhibit some, but not all of the spinal cord injury signs and symptoms we just discussed. Spinal cord injuries can happen via several different mechanisms. A compression injury can occur from a fall regardless of whether the victim lands on their head or their feet. Hyperextension and hyperflexion injuries of the spinal cord can happen from motor vehicle crashes, headfirst diving accidents, or other types of trauma that cause overextension or overflexion of the cord. Rotation injuries to the spinal cord can result from rapid acceleration forces and are common in higher cervical injuries at the C1 or C2 level. When the spine is pulled along its axis, this is referred to as a distraction injury, and a common example of this is the injury that results from a hanging. You may hear neurogenic shock referred to as neurogenic hypotension. This typically results from an injury to the spinal cord that leads to significant dilation of the peripheral arteries. Neurogenic shock happens when a spinal cord injury interrupts the sympathetic nervous system pathway. This usually results from injury to the cervical or upper thoracic spinal cord. As a result of the loss of sympathetic control over the vascular system, the peripheral vessels below the level of the injury will all dilate. A patient with neurogenic shock is not hypovolemic because there is no actual blood loss. It's just that the blood volume is insufficient to fill the vasodilated container. Unlike other types of shock, patients are usually awake and alert with skin that is warm, dry, and pink in color. Their heart rate will be bradycardic to normal with a normal capillary refill time, but they will have a lower blood pressure. Spinal shock refers to a transient loss of all spinal cord function, including reflex arc function, motor, and sensation, below the spinal cord injury site. Patients may present with a priapism or erection without sexual stimulation and loss of bowel and/or bladder control. Spinal shock patients may also present with bradycardia and hypotension if the injury site is above the level of the thoracic 6 vertebra. It is important to note that the ability to walk, move the extremities, or feel sensation does not necessarily rule out a spinal injury. Similarly, the absence of pain does not always indicate that a spinal injury has not occurred. Never ask patients with possible spinal injuries to move their necks as a test for pain. Instead, limit motion of the head and cervical spine by having your partner hold manual spinal stabilization while performing your assessment. Inspect and palpate for obvious traumatic injuries and check the extremities for problems with pulse, motor, or sensation. Determine whether the strength in each extremity is equal by asking the patient to squeeze your hands and to gently push each foot against your hands. Determine whether there is decreased movement and/or numbness and tingling in the extremities. Pain or tenderness when you palpate the spinal area is certainly a warning that a spinal injury may exist. Patients with spinal injuries may report constant or intermittent pain along the spinal column or in their extremities. A spinal cord injury may also produce pain independent of movement or palpation. Injuries of the cervical area may limit the ability of the diaphragm to function fully and minimize the ability of the chest wall to fully expand. Additional signs of spinal cord trauma are inability to maintain body temperature, priapism, and a loss of bowel or bladder control. Treatment of a suspected spinal injury includes maintaining manual spinal stabilization while the patient is being assessed. If airway management is needed, a trauma jaw thrust, as seen in the image on the left, is the best way to open an airway. If ventilatory support is needed, the rescuer at the head will maintain spinal stabilization while providing a trauma jaw thrust and securing the BVM mask to the face. A second rescuer will need to squeeze the bag portion of the BVM to provide ventilations. The patient should be moved to the stretcher while providing spinal stabilization, and the method used to move the patient will be determined by the position the victim is found. According to the National Registry of EMTs, spinal motion restriction is defined as attempting to maintain the spine in an anatomic alignment and minimizing gross movement regardless of adjuncts or devices used in the process. Spinal immobilization is defined as the use of adjuncts such as a cervical collar, longboard, and head immobilization to minimize movement of the spinal column. As we see in the flowchart on this slide, spinal immobilization is indicated for patients who have any focal deficits on the neurological exam, patients with altered mental status who are unable to meaningfully participate in spinal clearance assessment, and any intoxicated individual who is uncooperative in spinal motion restriction. These patients should be immobilized on a backboard or scoop stretcher with a cervical collar and head immobilization provided. Subsequently, spinal motion restriction is recommended for patients less than age 5 or over age 65 with significant mechanism of injury, patients with a distracting injury that is severe enough to significantly alter the patient's attention and make it difficult to assess other potential injuries, and any patient with spinal tenderness or spinal pain with movement. Current best practices recommend that spinal motion restriction should use a cervical collar, assisting the patient when moving to prevent any extremes of spinal motion, and ensuring the patient is secured in a position of comfort on the stretcher for transport. Here we see several devices that can be used to safely move a patient to the stretcher so they can be transported in spinal motion restriction. The vacuum mattress, long backboard, and scoop stretcher are good tools for moving supine patients, while the vest type immobilization device, more commonly known as the Kendrick extrication device, or KED, can be used to move a seated patient. As an EMS responder, you will be called to accidents involving athletes and motorcyclists who will be wearing a helmet and other protective equipment. Individuals wearing full face helmets should have the helmet removed to enable airway management and to evaluate for potential head trauma. When a motorcycle helmet, like the one seen in the image on the left, is properly fitted, it will maintain a neutral position for the rider when they are in a supine position. An improperly fitted motorcycle helmet can cause extension or flexion of the neck, which can be detrimental to an injured rider. Safe removal of a motorcycle helmet requires two providers, one at the victim's head and one at the victim's torso. The responder at the victim's head will maintain head stabilization, while the responder at the victim's torso loosens the helmet neck strap and grasps the mandible with one hand while placing the other hand around the back of the neck to the occipital portion of the victim's head. Spinal stabilization is transferred to the provider at the torso while the provider at the head carefully removes the helmet. Athletic helmets and shoulder pads are designed to work together to keep the player in a neutral position when supine. If the helmet with a face mask is still in place when the EMS crew reaches the player, careful removal of the face mask should be completed. Ideally, both the helmet and the shoulder pads should be removed together. This procedure requires multiple trained providers to safely perform the equipment removal. This can be done on the playing field or in the ambulance depending upon the circumstances. An athletic trainer or someone skilled in athletic equipment removal should coordinate the equipment removal process. It is possible to stabilize a player on a backboard without causing hyperextension of the neck when the helmet is removed and the pads must remain in place. This can be accomplished by the appropriate use of padding behind the head to maintain a neutral inline position. This brings us to the end of this presentation. Here we see the learning objectives for this module. Can you demonstrate each of these objectives? If not, consider going back to review any content that you struggled with. Thank you for watching this learning module.